Having me. Oh, the recording is in progress. Here we go. So, I have some slides, but before I start throwing slides at you all, I just want to get a sense from the people in the room as to kind of how comfortable and how much experience do you have with regard to the concepts and background and kind of history of human rights. So I have a little, we're going to do this with emojis. So if you're an expert, give me a horn. If you're an intermediate, give me a thumbs up. And if you're a beginner, give me the surprise reaction. And I kind of want to see where people are with regard to their experiences with regard to human rights. So we got lots of thumbs up. I don't see. Oh, we got an expert. It's good to have an expert in the room because that's not me, I'll tell you that. And I don't see any beginners. Okay, good. So thank you. So um, just by way of background, I also was asked to talk with regards to the organization that I'm part of, which is not affiliated with the University of Minnesota at all, which is Minnesota Doctors for Health Equity. And we are a physician organization that focuses on exactly what it sounds like, which is health equity issues in the state of Minnesota. And I'm going to talk a little bit about that, but my interest and kind of movement and work that I've been doing has been much more in the human rights domain more recently. So I'm going to start with some slides. If people want to turn the video cameras on, if they can, if they're able to, then that's great. If people want to throw questions in the chat or just throw up a hand while I'm talking, I will try to pay attention to that as well. So here we go. Okay. So, and let me organize you all so I can see people. Um, so I can see you all and I can see the chat. This is mission control. So before I begin, just a couple of words about me and about Minnesota Doctors for Health Equity. So as mentioned, I went to school in New York and I actually grew up in that area and ended up coming here to be an internist and a pediatrician. So I am board certified in internal medicine. I'm board certified in pediatrics. I see adults and children right now in the clinic setting. I work at a federally qualified healthcare center in Minneapolis. And I'm also the residency program director. So I kind of wear a couple of different hats in that capacity. Um, I also, in 2016, something happened in the United States. I'll leave that up to you. Um, got interested in the physician advocacy and the role of physicians outside of the four walls that we kind of work in the clinical setting. And I got together with a bunch of colleagues and we formed this sort of organization, Minnesota Doctors for Health Equity, and initially took on a fairly unusual kind of physician group angle, which is way back in 2017, there was this discussion about a provider tax, which is how we end up funding an aspect of our healthcare system in Minnesota. And we came out in favor of the provider tax because it was going to be repealed. And so we were basically a bunch of doctors saying, like, not only should you tax people, you should tax us until you figure something else out because y'all haven't figured anything else out. And so we kind of made a little bit of a name for ourselves in that capacity. So the repeal was turned around. It was not repealed. Um, they continue to tax physician and healthcare systems and have not figured something else out, but that's okay for now because things are already a challenge in terms of financial straits. So we've been doing work with community organizations over the years. And then, like I mentioned, most recently, become interested in human rights work and specifically the role of physicians and kind of more broadly healthcare professionals in human rights. And that's what I want to talk about right now. So I say bench to bedside, or actually bedside to bench, because really for our job, like my role as a physician, I engage with patients in the clinical setting and talk to them. Um, inside the exam room. And that's an enormous privilege. It's an opportunity to hear about people's um, experiences and perspectives in ways that I think many people aren't able to. And also, the human rights provides some framing for how we can go from what is going on with patients to what do we do outside of the exam room. And I know you are, many of you are not, most of you actually are not clinicians, but I think some of these same things apply when you're interacting with kind of people or groups of people um, in various settings. So I want to frame a couple of patients here. First, the man with an alcohol use disorder and chronic homelessness. There's a woman who's losing weight because she's not eating because she's prioritizing the nutrition of her family. There's an asylum seeker who fled their country because of fear of persecution. And then there's a patient who's in rural Minnesota who has to drive 4 hours for healthcare access. So these are all people who are in our clinic, in my clinic. I mean, you're going to see these are not unusual scenarios that I'm describing here. And so I want to start by just saying, what are human rights? And this is, by no, and I should say that I am certainly at the same level as many of you. I'm at the intermediate level. But I would say I'm at the intermediate level with a whole lot of people around me that I know who are really quite expert. So I've been like leeching off the expertise of them, not being an expert myself. So I would say that human rights are a number of things. One of them is that they are a philosophical approach to what is like, why do people have rights? What are rights? What are the, um, where do rights come from? That piece. And I think that's interesting. They're an aspirational goal such that everybody in the world should have a minimal set of rights. And then they are a set of declarations as well as international treaties that create a framework for human rights. And some of this stuff sounds really high-minded, but I think knowing the background is important, but also it trickles all the way down to those four patients that I mentioned before. And I think you can draw a direct line between the patients that I see in clinic or the populations that you may represent and talk about all the way straight up to the United Nations Declaration of Human Rights. And what I really like about human rights is that the main emphasis of it is on human dignity. And this idea of dignity seems like an unusual thing to hang your hat on when it comes to how you determine whether something is kind of good or not. But I think human dignity is really an incredibly powerful tool and an incredibly powerful approach to thinking about how people move through the world and how some people can move through the world in one way and other people can move through the world in another way, and how governments and bodies can either amplify or kind of hold up in an aspirational way the dignity of individuals or to attempt to strip people's dignity. The term dignity, by the way, again, it sounds like this is really like, a liberal arts degree kind of come to life. But it is a tool that judges in the international human rights community really use over and over and over again to determine whether a human rights violation took place or not. And so it really ends up being a linchpin of human rights. So human rights came from many, many places. I mentioned before that there was a long philosophical history, but the modern rendition of human rights happened in 1948 after World War II. And it was the creation of the Universal Declaration of Human Rights by what is now the United Nations. And at that time, it was a bunch of people from all over the world coming together in a room and really talking about what are the minimal standards that all people should be able to live their lives with and to have optimal kind of health. And the concept of dignity didn't really come up so much in this context, but more in the kind of the legal discussions afterwards. But the idea being, what is the minimum standards that everybody should live by? And there's a couple principles here around human rights that I think are really important. And one of them, and I think this is something that for as a physician, I'd like to say that I knew this before coming across this in human rights literature, but maybe I didn't consider it well enough. So human rights are for everybody, right? And so everybody is, deserves human rights. And that word deserve is really kind of problematic in these contexts because it's not that people deserve human rights. They have human rights just by being a human. Um, but one of the things that ends up like one of the litmus tests, and I think this is a litmus test that in the United States we fail over and over again, is uh, that if someone has one right taken away, for example, the right to freedom of movement, for example, because someone is incarcerated, does that mean they get other rights taken away? And the answer is no, it should not. They should not have other rights taken away. People in the carceral system should have the right to health care, to right to healthy water, to clean water, food, everything. And so I think in the United States, we really lump a lot of these things together and say, well, somebody has done something or is a type of person, and for whatever reason, they should have more rights taken away than other people. And I just don't think that is in the spirit of human rights. And the reason they matter so much is that they really define a ground level. So they are aspirational. And the aspiration is, wouldn't it be amazing if everyone in the world right now um, could have this minimal standard of human dignity that is written out in the Declaration and in the treaties? And so that's the aspiration. But the reality is that the thing, if you read the Declaration, the things are not that aspirational in the individual articles. Like the right to clean water shouldn't seem aspirational. It should be like people should be able to drink water. The right to healthcare shouldn't seem aspirational. People should have healthcare. But in combination, these things are aspirational. But at the individual level, each of these things form a floor, and everybody should be above that level. And I think one of the reasons they matter so much in the United States is that in the US, um, there's a lot said about US exceptionalism. And I think one of the views of that is that the US, is exceptionally good at certain things. And I think that's true. And I think the US also is the exception in many contexts. And I think that's also true. And in the human rights world, I would say that many principles of human rights are not something that we really necessarily think about explicitly in the United States. When you talk about the idea of a human rights defender in the United States is kind of an unusual title. In most of the world, and I think many of you probably know this way better than I do, in most of the world, a human rights defender is pretty much everybody. And that is not an unusual statement. I think the most amazing thing to me about an amazing, this is not a good amazing, this is like a flabbergasting amazing, is this picture, which is there's the Convention on the Rights of the Child, and every single country in the world, except for the United States, has adopted this convention. We signed it, but we haven't adopted it as law. And there are many, many reasons for this, and some of them are horrifying. For example, one of the stated reasons, or one of the reasons, is that the Convention of the Rights of the Child prohibits children being put to death via the death penalty. And so, at the time when this was being discussed in the United States, that we were doing that, and we said, well, we can't sign on to this treaty because of that. So that is horrifying. And then there are other issues around that, beyond that as well. So I would say United States exceptionalism really kind of cuts both ways. So that's kind of the background of human rights and where they come from, to a certain extent what they are. But there is also some properties of human rights that I think are really important to understand. And this allows us to build a framework for human rights that allows us to then use these tools in a variety of different contexts. So human rights are universal, inalienable, indivisible, and interconnected. So universal means simply they apply to everybody. Inalienable means you can't take them away, like the government or an actor, like a corporation, can't take them away from individuals um, without significant due process. And there's a few exceptions, like criminal law, but other than that, they really cannot be taken away. They're indivisible in the sense that it's almost impossible to say you have the right to freedom of speech, for example, if you don't have the right to freedom of movement, and if you can't eat, and if you can't drink, and if you don't have health care. It's pretty hard to be able to have freedom of speech if all those other things are taken away from you. And so it's very difficult to kind of tease them apart. And in the same way, the kind of inverse of that is they're all interconnected, and I'll give you examples of that in a few moments. I mentioned this already, but in most countries in the world, everyone is a human rights defender. In the United States, it's typically lawyers. It's kind of in the domain of lawyers are often considered human rights defenders. And then perhaps nonprofits and some individuals who might consider themselves that. But it's certainly not ubiquitous. One of the mainstays around human rights, and this is where it gets to being able to hold governments and corporations by extension accountable, is the obligations that these entities have. So the obligations of a government and therefore the entities underneath them are to respect, protect, and fulfill the individual rights. And you can see what I wrote here about what that means. Um, the idea is that people's rights need to be respected by the government. They be protected by the government in the sense that they are not going to be stripped away, and then they have to positively act in a way to fulfill the right. So if you think about the right to healthcare, the government needs to be taking steps such that all the people um, under its authority will eventually get the right to healthcare. So I'm going to jump back. So that's like a very quick primer on um, human rights. I'm going to jump back to the cases I mentioned, and here are the four of them. Again, a man with alcohol use disorder, chronic homelessness, woman losing weight, an asylum seeker, and a patient who's driven 4 hours. I'm going to talk about how each of these, oh, um, how each of these perhaps are considered are right, the rights that are related to this. So, man with alcohol use disorder and chronic homelessness, there's, I would say, his right to housing is violated. One of the powerful tools, at least in the clinical setting, and I would perhaps argue that in other contexts that you may kind of find yourselves in, is that a human rights framework allows us to name the violation. And I think when we call something a violation, it is much more powerful than saying, oh, well, this person is homeless. And so in the clinical setting, we might think about somebody being homeless. We might think about like the barriers to housing. We might think about the social determinants of health and how they relate to housing. But I would say it's another step to say that person's right to housing is being violated by the government and by the entities that exist in the United States. And I think that's a much more powerful kind of statement than kind of it kind of draws a direct line of agency between the person not having housing and the fact that person's right to housing is being violated. So similarly, an asylum seeker going from one country to another has a right to asylum. That's one of the rights in the UN Declaration. The right to health care. Um, and so, sorry, and then the right to healthcare. And I'm going to explain why in a moment, why driving 4 hours is an explicit violation of the right to healthcare. And one of the things that this framework does is it allows us to name not only the violation, but to say why there's a violation in the right to healthcare. So there's an approach to advocacy here. And the first is just identifying what is the violation that is happening, what is the human rights violation that is happening. And then there's a variety of methods and tactics that you can see here that kind of escalate that observation to an actual remedy, whether it be the remedy for the individual, for the population they represent, or for the population as a whole. So going back to the Minnesota Doctors for Health Equity piece. When we started way back when in 2017, which is much, much later than what, 1907, I think you said. So, we're a much, much, much newer organization. Is we just took this approach of the levels of levers. There are different levels that people can act in when they're being advocates, individual system, community, and government. I think this is familiar to you all. So the human rights kind of approach does something similar. However, they kind of center the person, and it's the person whose right is violated. And interestingly, when people who are true practitioners of this, who go from bearing witness to human rights violation all the way to kind of litigating one and making policy and legal changes to it, they kind of take the person whose rights are being violated and explicitly identify the person who is violating that right as an actor of the state. So there's no like vague hand waving here of like, well, this person is homeless. It is this person is homeless because of the actions of this person who is acting on behalf of the government, which I think is a whole different level of accountability. And so the same thing would apply to the community. This person is a member of the community that typically, if a member of an individual's rights are being violated, often the community's rights are being violated. There's a system, there's a government that is responsible for kind of these concentric circles underneath. And then there are international bodies that we can at least theoretically appeal to get remedies for people. So I'm going to focus the rest of the time on the right to health a little bit and to provide explicit examples of how this plays out. So this is literally the right to health from Article 25 um, in the United Nations, the UN Declaration, the Universal Declaration of Human Rights. So I'm going to let you read that for a moment. Seems pretty straightforward. There's mentions of food, clothing, and housing, and that gets at the kind of um, the interconnectedness of the various rights. All right. So what's interesting is that since the Declaration of 1948, there's been a lot of work done in the legal community on these things, and each article has basically this kind of write-up by a body in the United Nations that kind of breaks down how do you know that this right is being violated. And so in the state of healthcare, there's this AAQ framework, and you may all be familiar with this framework. And if you are, I'm sorry for kind of uh, belaboring the point. But in order for someone's right to health to be fulfilled, healthcare needs to be available, acceptable, or accessible, acceptable, and of high quality. And I'll go through each of those as an example of when that is not the case. So these are the people that I mentioned again. And oops, sorry. This is not what I wanted to do. Just kidding. Okay, I'm gonna do this. So what it means to be available is that it's exactly what it sounds like. So the person who has to drive 4 hours in rural Minnesota, their right to health is being violated of healthcare. So that's the first piece, and it has to be available. Accessible means that not only can you get there, but you have to be able to get into the healthcare and either, make an appointment, meet with somebody, um, navigate the system. And if you cannot do that, that's a violation of right to health. It has to be acceptable if somebody speaks a language interpreter, language other than English in the United States, an interpreter needs to be available. If somebody is trans, having, kind of an approach that is gender affirming in the clinic would get at the acceptability of healthcare, for example. And the quality means that once you get all these things, that's great, but you still need quality healthcare, meaning that it is evidence-based and to kind of the community standards for a given disease process in a population. So I'm going to jump forward a little bit. And the main kind of tool that is used in human rights work with regard to this is bearing witness. And this is something that we can do in the clinical setting, but anybody can do in any setting. And bearing witness means observing what is happening in the world around you or to individuals. But it's more than that. It is literally documenting it in contemporaneous notes, either in a legal capacity, like in a medical record, or in a private capacity. Operation Metro Surge was an example recently of many, many instances of bearing witness, both via video, via the written word. Right now there's a truth commission that is trying to compile all those stories, that information to form a narrative about what happened in Operation Metro Surge that then can be used in the future for legal proceedings. And also, if we come down to it, like a Truth and Reconciliation Commission and even reparations, that kind of thing. Um, I think, one of the things I talk about a lot is, and this group kind of already knows this, but partnership with other groups that are doing the work is critical. And there are many groups that are doing specific work, and actually the human rights community in the Twin Cities is pretty remarkable. The gender justice at the university. So, just some practical things that we do in clinic, and also that you all can start doing if you're interested in pursuing some of this. So, one is we have a medical legal partnership at Kook, which is the FQHC that I work at. It's the first medical legal partnership in the country, so it's the oldest medical legal partnership in the country. And we work very closely with their attorneys to help patients in a variety of legal capacities, but mostly recently it's around immigration, and specifically um, habeas corpus petitions, which is what we were doing a lot of during Operation Metro Surge. But I would never even know what a habeas corpus petition was if not for the medical legal clinic that I was a part of. And so that's a powerful tool. I think every hospital system and clinic should have a medical legal clinic. The other thing uh, that we do is that I'm doing is a number of us are practicing asylum medicine. So my asylum medicine is doing uh, medical evaluations for people seeking asylum to be kind of objective experts with regard to their experiences and also the the psychological and physical trauma that people have undergone for the purposes of their asylum claim. So if anybody wants to know more about that, I'm happy to talk about that. Court observation, this is something that anybody on this meeting can do, and I really encourage people to at least do it once at some point. So the Advocates for Human Rights have a court observation project for immigration court, and the Acacia Center for Justice has one for pediatrics. And basically what this is, you do some training, and then you go to court either physically over at the Whipple building or virtually, sometimes in other states or sometimes here, and observe the proceedings with regard to what's going on with um, the people who are going through the process to make and having using a checklist essentially to make sure that their rights are being upheld. So, like, is the child alone without an adult in the room? Um, is an interpreter being used? Is language, appropriate for in the context, that kind of thing. And so you can sign up for these and do them, and they're really pretty powerful. Um, this is just to speak to some of the stuff that Minnesota Doctors for Health Equity did. I mentioned Minnesota Care, and we've been working with the Minnesota Budget Project, which they have. This is Medicaid Coalition, and we're a member of the This is Medicaid Coalition. So, and then I'm doing some work on racial equity impact notes. And we are teaching this as well at the University of Minnesota. We have a health and human rights course through the School of Public Health that we've been running. So This is just some links if you want to learn more about human rights, and I can send these out. Um, I think the bearing witness and taking notes, and I put this ethically because I think it's important to recognize that one of the mainstays of bearing witness is to recognize that it's not our story to tell. It's the person who was affected, it's their story, and we need to get explicit permission from people and do it so in a way that's ethical. So, for example, I really can't get permission from one of my patients to tell their story because of the power dynamics in the room. That is not appropriate. Um, but we do need to be able to try to connect people with the ability to share their stories because that's so important. Um, and then find partners. And yes, Dr. Diner, and then his brother was a pediatrician, and the clinic is actually called the Diner Clinic in at Kook. I don't know if that was on the slide or not. So that's all I have. This is just again like a quick what is human rights and how might people use some of the frameworks. I'm happy to answer questions or to just have a conversation and go from there.